that were particularly powerful for me. So the first one, CCT junior, 8-year-old boy comes in after being an unrestrained backseat passenger in an MBA in which his stepfather was intoxicated the day after the party. So he comes in unresponsive, intubated, hand scanned. He continues to be unresponsive. Scans are all negative, but basically has no brainstem reflexes. So as a junior, I go in, I'm putting a femoral line because we're about to start pressors, and literally crying by myself in this room. Didn't tell anyone that this happened. I don't know if anyone knew. Attending was particularly helpful on that day, but still pretty powerful. So the second one, 7-year-old girl, pedestrian struck, comes in dead on arrival. I was a CCT senior. Fortunately, unfortunately, I didn't have to deal with the death notification procedures. Happened to be a particularly busy day, back-to-back trauma codes, but I still remember being so busy and then sitting there hearing the girl's mother crying in the hallway while we're trying to. All right. And then, of course, special thanks to Dr. Smith and Willis and Rios as well for helping me with this presentation, and thank you to Dr. Aquila for joining us today as well. So culturally, for whatever reason, more and more patients today are dying in hospitals, terminally ill patients, nursing home patients, going to the hospital to die. This makes us have a disproportionate number of patients dying in the emergency room, accounts for about 0.2% of visits. On average, EM physicians report experiencing patient death about once a month. Deaths in the ED are sudden, they're violent, patients are often young. We have no rapport with these patients, we have no rapport with their families. This is a very tough situation to be in. Because of this, patient families often have displaced anger, they have displaced guilt towards the physician. Imagine coming out of a resuscitation, you're emotional, you're exhausted, and the family becomes angry with you after you give them this news. Additionally, the ED is just a terrible place for dying patients, for their families. Where are they supposed to go? There's patients everywhere. Even though our staff and our nurses do an excellent job trying to give the families privacy, they'll often give them a private room in CCT, they can take their time. It's simply not enough. There's still patients everywhere, people are walking around. And I think we've all been in situations, you're in and out of the code, and then someone walks up and asks you for a sandwich. Seriously? Alright. So this is a pretty intense topic, it's pretty emotional, so I'm going to try and just sort of go over everything as objectively as possible. I'm going to talk about what I've learned from what I've read, kind of try and look at specifically at how this affects us as EM physicians. And then finally, let's look at some objectives, some tools that we can use to help ourselves cope and help ourselves become more educated. So, yes, this is my 60-pound dog on my lap. And yes, in Brooklyn, everything has to have two purposes in your apartment. Dog, table. So, I found that there is a lot of research out there, especially in the past 5 to 10 years about this topic. Most of it, however, is observational, self-reported surveys or semi-structured interviews, and most of it comes from oncologists, pediatricians, and often nurses. What we've learned from these studies is that yes, physicians cope, they grieve, they experience intense loss. Younger physicians tend to internalize this loss, they experience it more deeply, and they tend to place blame on themselves after a patient dies. They think, well, what if a more experienced physician was present? Would this patient really have died? We also know that physicians can experience burnout as a result of patient loss. They report physical symptoms, symptoms of PTSD. In some surveys, 9% of psychiatrists, after experiencing a patient's suicide, consider leaving their specialty. 10% of OBGYN physicians, after experiencing a stillbirth, reported similarly that they considered leaving their specialty. All right. There was one study that sort of gave us some information out of annals of emergency medicine, specifically at academic emergency physicians. So basically studied faculty at 4 different EM residency programs. had an okay response rate. This is also fairly recent, 2010. There was 4 themes that developed from this survey. First of all, training was limited for the faculty. None to up to 6 hours was the majority of the responses regarding the training they had received. Debriefing after a patient death was very rarely reported. Again, physical responses were common: insomnia, fatigue. Some common coping mechanisms kind of keep popping up over and over again. The most common are talking with colleagues, talking with family, and then simply continuing to work. 6% of physicians in this survey also reported using alcohol to cope. We don't know, is that just getting a drink with colleagues after work, or more of a severe use, but still. Also think continuing to work, this is kind of twofold. Yes, this can be sort of a productive coping mechanism. Physicians, especially in EM, tend to be extremely task-oriented. Kind of makes sense. And also, this is just the nature of the emergency room. You sometimes have no choice but to continue to work. So, not all patient death experiences are negative. In a qualitative study of palliative care nurses, it was shown that these nurses, although they experience the same stress levels as their colleagues in other specialties, actually have higher satisfaction regarding their careers and a strong sense of commitment. Same is true for physicians who experience death that they perceive to be a good death, so a death in which you're alleviating the suffering of your patient. So I think this quote is particularly powerful. This came from one of the medical student interview surveys that I read. So it shows a very mature coping mechanism, so I'm just going to read it. So I think that maybe one thing that saves you as a physician. There's always somebody else there who still needs your care, so you have to keep going. I think it can be appropriate to have your moment of grief and then stand up and say, well, I'm a doctor. I'm going to know a lot of people who pass away. People pass away every day. It's sad. But there's always somebody out there who I can still help. So kind of going with the theme, yes, we have to continue to work, and maybe if we focus on that, it'll help us get through. All right. So thank you to Dr. Blumenberg for pointing out this clip that I'm going to play for you next. And I also, Dr. was giving me permission to comment that while reviewing my lecture, looked at the clip and then proceeded to watch more scrub clips for 30 minutes.
Dr. Wenderman, he's explaining to that family that something went wrong and that the patient died. He's going to tell them what happened, he's going to say he's sorry, and that he's going back to work. Do you think anybody else in that room is going back to work today? That is why we distance ourselves. That's why we make jokes. We don't do it because it's fun. We do it so we can get by. And sometimes because it's fun. But mostly it's the getting by thing.
It's come to my attention.
This is physician, medical student, nursing student, resident level. There has been an increased push, I would say, at least over the last several years to change medical school curriculums, change residency curriculums, increase our training regarding palliative care, end-of-life issues. A lot of the times this is sort of more of the procedural stuff. So what happens after a patient dies? What's the death notification process? What happens organization, what happens procedurally. And these things need to be discussed, but they're clearly not sufficient for anyone's education. Medical students in particular have been shown to place such a strong value on the informal education, sort of the stuff they learn from experience. Clearly, they know they need a base, but we definitely also need an increase in our formal education. So in light of all of this sort of push and this sort of trend to increase our educational experiences, a lot of authors decided to look at what do med students experience in their first deaths and what do they expect to learn regarding palliative care. So some common things that came up. So contrary to what we previously thought, medical students did not think that death was a failure. A commonly cited reason why physicians feel so much guilt after patient losses, maybe this, we're trained to be like, we want to save people, this is something that we failed. Again, they're more sensitive to the informal curriculum and the examples that are set by the leadership. They respond extremely well to attending support. Many reports of debriefing or crying when an attending physician was present and feeling supported was very well received. They also experience similar coping mechanisms that we do once we are officially physicians. Again, talking with colleagues, continuing to work, also reported just sort of participating in the death ritual, whether it's with neonates, as well as simply, just crying or kind of moving on. An interesting study, this is one that Dr. Rios shared with me. This was actually done out of Mount Sinai School of Medicine and looked at students on their third-year clerkship and actually surveyed the students once a month for the entire year of their clerkships and for various aspects. The thing that I wanted to point out was that students who reported an increased number of traumatic events, which included patient death, but it wasn't limited to patient death, had higher scores on scales of professional development and had no change in anxiety or depression over at the end of the year. So interesting that sort of, it's unclear why, but there's some sort of resilience that they're getting. Are they learning kind of coping styles that they need to get by? All right. So before I switch gears and talk about some of the tools and some of the things that we can do to improve education, I want to stop and sort of have a discussion with everyone. I know we recently did this a little bit in light of events unfortunate events in Kentucky, but with our residency leadership. So I wanted to sort of start there, if anyone wouldn't mind sharing their experiences. And if I want to take it a step further and say, did you debrief in the emergency room? Did you have time to cope in the emergency room? How were you supported by your attendings, your senior residents, and then kind of what happened after that? Anyone is willing? Go ahead, Bart.
I guess so. Intern year, there was 2 medical resuscitations involving peace patients. They both passed. And the second one, I looked around the room and I was the only one that was there for the previous one, and this happened within the week. So I just took a long walk around Central Park with my headphones in and just needed something to just get my mind off it all the next day at all.
Thank you.
Could you repeat that? I couldn't hear it.
So intern year, I was in a couple of peace codes, both passed, and this was within the week. And the second time, I was the only resident or the only person in the room that was there for the first one. So the next day off, I just took a 2-hour stroll around Central Park with my headphones in, just to get my mind off things.
This last year, this young guy came in and he had been stabbed to death. He was definitely dead. There wasn't a lot of debriefing going on in the ER, but it was hard for me because it was just so violent. This person died with so close contact over and over again. It took me a really long time. I talked about it a lot with kind of close people who would listen, but it was really brutal.
Adi?
Yeah, mine is about a pediatric case also. I think just with the younger population, it takes you a little bit more.
I remember like within 1 month of coming back from maternity leave, we had an 8-day-old that came in dead. She was sleeping next to her mom, and I don't know if it was the mom rolled over, we don't know what happened. However, the baby came in lifeless. You know, the baby had blood coming from the mouth. I had to intubate the baby, but as I was looking at the lifeless body and intubating, I mean, as a mom, it really moved me. But even as a person in general, it just really moved me. But I had to continue to just like kind of go through the motions. We didn't debrief after, but after I did talk about it with some friends. But it was just, you know, hearing the mom cry and say, why my baby, was just really hard to watch. It was hard to break the news to her. Obviously, she knew the baby was dead, but, you know, it's just something that, you know, it was tough.
Liz?
When I was an intern, I didn't see a baby that was my first year, but at the end of the year, there were 2 in one day, and I didn't know how to handle it, you know, and I think and I looked around, and other people just didn't really seem to be crying, or didn't really seem to be affected, and I think it was really hard for me to figure out who to go to, and what I didn't realize, and the reason I'm saying this is, especially for the juniors, is that you can come to us, you know, and our faculty are spectacular. They get it. You know, people are happy to take you aside for like 5 minutes and talk to you. And so what I learned from that experience is that people are there, and that for me personally, that while I'm fine in the moment, that I must do something afterwards to debrief with colleagues, or to find a way to deal with the energy that's come up with that, because otherwise it's going to leak back into it.
Thank you, Liz. Did anyone have any deaths where they sort of felt, it was sad, but it was, sort of like good death that I mentioned, or you felt increased satisfaction, or with the help of patients?
Yeah, and I think that I've seen a great progression of that just in 5 years of residency, is having just frank conversations. One of the best, and the only time was a resuscitation with Dr. Martindale. That it was the first time that I had the opportunity for a family to be in resuscitation, and it was amazing. Being able to see them make the decision to stop actually helped a lot in dealing with that death. The spectrum of how people react to the news of a loved one dying is huge, and we've all seen how diverse it is. But that was a great death in one that wasn't expected. It wasn't like a DNR, contracted, came in, probably has been alive for a very long time, in not a very comfortable state. This was a very much unexpected death, but they had the power to make that decision, and they made it, and it helped a lot.
This is actually not my death, but one of my colleagues that I respect and look up to very much actually received one of my patients. So she had a big ICH. She was totally fine, a very well 84-year-old lady, and then she was found by her son a few hours later, and it was like very obvious that she had an enormous bleed. And in the moment, I tried really hard, and she was agonal when she came in. I tried very hard to sort of tell the son and try and approach the should we not intubate this patient conversation, giant brainstem bleed. And unfortunately, I ended up doing it for a variety of reasons. The son wasn't ready, he needed his brother, et cetera, et cetera. But what I know is that summer, later, once the whole family was there, was able to have a real end-of-life discussion. And when I followed up on the patient, Summer said that they extubated the patient, he stayed with her, and she passed very calmly. And I can't think of, if we hadn't intubated her in the first place, it would have been best, but rather than a long, protracted course with a peg tube and a trach and blah, 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 she was able to pass, and I felt very good about that. Wasn't easy.
Okay, just before we move on, has anyone ever actually had a debriefing after a patient death? Yeah. I've heard Dr. Chow's.
I hope everybody's doing it.
I've done it every death I've done for the last 15 years.
Good. I guess I should reword that in terms of more like your experiences. I know often we debrief after sim and we're used to debriefing the case, but I mean more of an emotional debriefing. So yes, the Dr. Aquila has, but go ahead.
This is kind of the only death that I still think about, and it was when I was an intern and I was at UHB, and I just remember this because I think oftentimes our patients come in and service us and you don't really ever know them. So when they pass, it's, I don't know if I just am a cold person, but it doesn't affect me so much, right? I just remember there was an older woman in 1A, I was looking over at her, she was with her daughters and she had come in for a call or something, and I went to go and see them. It was a really busy day. And the daughters were really sweet, which you also don't always come across a family that is really wonderful. And she just came in with a cough, right? And I went back to document, and she decompensated so quickly. I don't even remember. We were just rushing her into the resus room, and she was unresponsive at that point. But I was just speaking to her a few minutes ago, and I was with Rodrigo. Half of us know it was obviously wonderful, right? So you can anticipate that. I was with Dr. Palino as well, and I just remember we were doing CPR and I was intubating her, and she ended up passing. But I was in the room, in room 9. We were able to get the family into room 9 at UHB, and we sat down with him, and I was just present in the room when Rodrigo was notifying the family. And it was such like a nice experience, and I think that just goes to show one way that can help you through these experiences is to actually interact with the family. It seems to be like a really sad interaction, but it's actually nice. It gives you some closure as well if you can give them some comfort. So, and we debriefed the case.